Well, good afternoon. I'm Helen Kornman. I'm co-chair of the GAP, and I'm here with my esteemed colleagues who you'll be introduced to a little bit later. The Global AIDS Policy Partnership welcomes you to our webinar on how PEPFAR can be used as a platform to address COVID-19 and future pandemics. The GAP represents more than 70 organizations, including advocates, civil society, and implementers committed to improving U.S. global HIV/AIDS programming. We are very proud of what the PEPFAR mechanism has achieved in more than 50 countries under the current leadership of Dr. Anjali Akrekar and incoming appointee-elect Dr. John Nakangazan. PEPFAR has partnered with countries and communities to save more than 21 million lives to date and prevent millions of HIV infections. And yet HIV progress is in jeopardy due to COVID-19. The Global Fund recently reported that HIV testing has declined by 41%. TB deaths rose for the first time in more than a decade, and economic challenges continue. In addressing COVID-19, PEPFAR has proven itself to be an invaluable asset, building trust amongst communities and leveraging an existing infrastructure and local partners. HIV treatment has been preserved and increased. Its speed in obligating funds, building on-the-ground presence, and ability to mobilize and remunerate community healthcare workers allow it to operate with the ongoing flexibility that is necessary in a pandemic. Today, we will hear from 3 different panelists who will discuss the power of the PEPFAR platform and how, as U.S. Secretary of State reflected on a recent trip to Nigeria, this pandemic has revealed how vulnerable all of us are. We have to seize the opportunity to strengthen global health security. We've spent decades working together to improve health across the continent. PEPFAR, for example, has saved millions of lives, brought the world to the edge of the first AIDS-free generation, and transformed public health infrastructure. I'm now going to turn it over to our moderator, Jen Cates. Jen Cates is Senior Vice President and Director of Global Health and HIV Policy at Kaiser Family Foundation, where she oversees policy analysis and research focused on the U.S. government's role in global health and on the global and domestic HIV epidemics. She's also a longtime colleague, and we all know that Jen can offer us another perspective. But before I do that, I just want to say that we have a lot of folks on the line today. So as you have some thoughts and questions, please do put it in the chat and we will get to them as we can. So again, thank you for being here, and we hope that this will be a lively discussion. Jen?
Great, thanks so much, Helen, and thanks to the GAP for convening this and asking me to be here. I'm just going to provide a few remarks to set some context, but as you are, I'm looking forward to hearing from our experts because they're going to share what is actually happening on the ground and what we're, what the challenges and the progress is. It goes without saying that the disruption caused by COVID-19 has been felt everywhere. Not only are we still operating in the context of that pandemic, but the health and the economic consequences will be felt for years to come. I mean, just look what's happening right now with South Africa and the travel ban on that country, preventing economic activity and once again showing the linkage between the two. In the midst of all this, PEPFAR early on worked to respond. I think in the beginning, everyone had their heads down and we're just trying to get things done. But PEPFAR, being that it's the largest HIV donor in the world and combined with the Global Fund is virtually all of HIV funding, external HIV funding in the world, understanding what PEPFAR did, how it did it, and what needs to happen still is critical. I think we all know that PEPFAR provided operational guidance, flexibilities, pivoted in many ways, received emergency funding from Congress of $250 million, which really was designed to address not just what PEPFAR was trying to do for COVID, but to maintain its ability to keep people with HIV and those at risk connected as much as possible. So it was a double use of that. The end result, as Helen already alluded to, PEPFAR has seen ARV treatment continuity not only maintained, but treatment is up. And PEPFAR has documented that there were actual disruptions to prevention services earlier in 2020, or probably third quarter, second quarter, but those seem to be returning now to prior levels. So that's really important. And I think, as we think about the future and what PEPFAR may be able to do, we know that it's going to be highly dependent on a few things. First, COVID-19 vaccine rollout. Without further COVID-19 vaccine rollout, PEPFAR's own ability to sustain these gains will be significantly challenged. Second, I think we all know that PEPFAR has, it's funded over $5 billion, but that's been relatively flat for several years. So its ability to achieve further gains on HIV, let alone address COVID, is challenged if there's not additional resources. And then, of course, the COVID pandemic itself, we don't know what's going to happen with COVID. I think anyone who tries to make any prediction will be proven wrong. So none of us should make predictions about COVID. We should just know that we are living in the midst of a pandemic while still trying to address HIV, another pandemic, and there's a lot of uncertainty. Myself and I think several of you listening and those who are presenting today have had the benefit of listening to or hearing some presentations from OGAC recently, broad overviews of what OGAC and PEPFAR has done in DC and then at country level to be able to maintain services as much as possible. And today, what we're going to get is a much more specific sense of what that actually looks like and what that means in certain countries and what it might mean for the future. So I'm going to introduce our experts and then turn it over to each of them. And then we'll have a short panel discussion between us and go to your questions. So first, we have Dr. George Siberry, who's a pediatric infectious disease physician who's been at USAID as a medical officer in the Office of HIV/AIDS since September 2018, I believe. At USAID, he is a deputy principal and a senior technical advisor for adult and pediatric HIV treatment. And he's also been a principal OHA representative for the interagency PEPFAR COVID team and has acted as a senior clinical advisor for the USAID Global Health Bureau COVID-19 Technical Working Group. So we'll hopefully benefit from hearing about that. We also have Dr. Muka Chukuba McLeod, who has over 25 years of experience in medicine, epidemiology, international health, and development. She's managed several public health projects, including 4 USAID funded projects. Her areas of expertise include internal medicine, infectious diseases, disease surveillance, and research. Muka is the project director for the USAID Discover Health Project, which supports health service delivery and social marketing programs in Zambia. And finally, Dr. Kimberly Green, who leads PATH's primary healthcare program. And prior to this, she led PATH's global HIV and TB portfolio, including the USAID PATH Healthy Markets Project, which leverages innovation and partnerships to increase key population access to essential health services. Dr. Green has nearly 30 years experience in public health management, policy development, and research. So thank you all 3 of you for being here. Doctors, I think we'll start. Is George going to go first then, I believe? And the slide masters will make it work and seamlessly go forward. Thank you.
Well, thanks, Jen, very much. George Siberry here. Really appreciate that sort of framing and happy to offer a few minutes of sort of overview of how we've seen real success and promise for how PEPFAR has been instrumental in not just responding to COVID, but making sure we're taking care of the staff and clients of our PEPFAR programs as we do it. So next slide, please. And it really does come down to those 2 big categories as we thought about PEPFAR's role and response during COVID-19. On the left side, those are sort of the categories and activities that represent protecting the HIV response in the face of COVID. And on the right side, that's really leveraging the assets and resources and platforms of PEPFAR to contribute to the COVID-19 response itself. And these two things are both incredibly important, highly interrelated, but end up worth sort of discussing separately because they may have approaches and funding streams that are somewhat different. So on that left side, you can see, as Jen alluded to, despite COVID, because of the way that our implementing partners and staff were able to be so nimble, they were on the ground and working, creative and adapting the way they delivered HIV services, we were able to maintain the clients on treatment and even grow that number. And though there were disruptions in some prevention activities like VMMC, actually rebound on those and PrEP and testing in ways to make sure that we were able to end up ahead of the game despite COVID. And I'll mention that HIV self-testing is a good example of an adaptation that got accelerated as a way to help in a safer way deliver testing services for HIV during COVID. On the right side, that's, I think, examples of where the investments that PEPFAR has made through its implementing partners, partner governments, and others in things like testing and diagnostics, in vaccine readiness, in prevention and control measures and clinical measures, in data monitoring and evaluation structures, and especially in supply chain, that all of those stood ready then to be used and serve in the COVID response itself. Next slide. Now, Jen referenced the $250 million that was given to PEPFAR of ARPA funding to do two major things: to help mitigate the impact of COVID on the HIV response, and then also in the context of the HIV programming to contribute to the COVID response itself. And so this was organized and coordinated by OGAC through the agencies that then work through the partners to deliver these services. And part of this was making sure we understood the impact on prevention services and how we could make up for that, how we could understand the impact COVID might have had on normal HIV laboratory services and on supply chain, and how we could make up for those damages and losses in activity during COVID. And then on the flip side, in the context of partners who were putting their own lives at risk as we were coming to try to understand better and more about COVID, how we could do how we could do more to ensure that we protected the staff and clients as we delivered HIV services through IPC, vaccine support, testing, and clinical management. Next slide. And I think here is an example with vaccine support that's a really good one, where in the context of PEPFAR itself, because we've got support to people, structures, infrastructure like supply chain, and clinical management partners, that in the context of all those activities and all those resources, we have really identified very specific ways that PEPFAR can deliver directly the kinds of services and even vaccines in arms that are going to make a big difference in winning this fight against COVID-19, and especially for the people living with HIV and the communities where they live. Next slide. Now, the other side of this is thinking all of the work that PEPFAR and through the Office of HIV/AIDS at USAID has done and invested over years for HIV programming globally stood ready to really then be used to also deliver COVID response. And this included supply chain systems in 58 countries, surveillance systems, health infrastructure across 9,000 facilities in 40 countries, almost 100,000 directly supported healthcare workers, many awards, and these were both local awards as well as international partner agreements, digital solutions that had been developed for HIV services that then would be able to be used, modified, and leveraged for COVID services, and research sites throughout Africa and India that enabled the delivery and implementation of important research for COVID. Next slide. So early on, when in this epidemic, PEPFAR funded USAID central mechanisms, these are PEPFAR mechanisms, were modified so they could accept COVID funding, so that the COVID ARP and other funding that came to USAID could go in a large way through these mechanisms. These were on the ground, nimble, trusted partners already ready to move quickly to deliver high quality COVID response. And you can see it's all listed here. It costs the whole area from supply chain to clinical services to infection prevention and control and vaccine readiness. Next slide. So you can see, again, when we think about PEPFAR supported staff, we can think about how those staff were able to adapt HIV service delivery on the left to do things like stress multi-month dispensing and emphasis on client access to treatment, and doing that with remote and virtual approaches for other services as well. Adapting that HIV service delivery was one side, and then on the other side, leveraging the PEPFAR supported infrastructure to do COVID work like screening, IPC, risk communication, and vaccine readiness and administration. Next slide. Similarly, supply chain systems, PEPFAR and USAID supported, adapted on the left to deal with supply chain disruptions, to make sure that they did their level best to make sure that there were no disruptions or interruptions in treatment for HIV, and that HIV testing got back up to speed as quickly as possible. And on the right, those same supply chain systems were what helped very quickly be ready to deliver the commodities needed for COVID protection, COVID treatment, and the cold chain management that was relevant for vaccines. Next slide. These USAID OHA PEPFAR mechanisms also were used to a huge extent with a lot of the USAID COVID funding to deliver, you can see here, a whole range of wraparound services. Again, these partners were present in many countries. They were already trusted by ministries of health, already connected to many facilities, connected to other aspects of the health systems, and were able to pull this all together when given funding to do COVID work to quickly put together fantastic COVID assistance. Next slide. I'll give you two quick examples. So EPIC is one of the large USAID funded PEPFAR partners. They're present in 43 countries, and you can see why they were so ripe, if you will, to be ready to do a lot of the COVID assistance with money that came through USAID. And on the right there, it's detailed there, but you can see what they did varied by what was needed in the country and where they could make the biggest difference. And they were able to move extremely quickly because they were already operating in all of these countries. Next slide. Similarly, RISE, another large project, lots of clinical and other expertise for delivering HIV services on the ground in these 13 countries and ready to go with additional COVID funding to work on very specific, and you can see broad aspects of the COVID response, and to great effect. Next slide. I'll just mention briefly that those partners and other partners, including local partners, also were able to receive USAID COVID funds to work on essential parts of the COVID response, like strengthening the oxygen ecosystem, strengthening laboratory services like genomic sequencing, critical for detecting new variants, and mental health and psychosocial support to make sure that they were thinking about the burnout of the healthcare workers who were trying to do all their regular work and then the COVID work and worry about themselves and their own families and communities on top of that. Next slide. So in summary, the reasons that I believe we've seen such success in PEPFAR's role in helping with the COVID response is this twofold aspect: the dynamic adaptations that we've been able to see the partners undertake to deliver the essential HIV services while protecting HIV program clients and staff from COVID-19. And this includes direct promotion and administering of COVID vaccines through those footprints, the ability to leverage PEPFAR-supported health infrastructure and systems for delivery of skilled, nimble, and rapid COVID assistance. And again, the fact that these partners were already so expert, so able, and had trusted relationships with host country governments and others in country enabled them to move fast and well. And then finally, flexibility, ensuring right from the beginning that these mechanisms had the flexibility to receive COVID funds, even though they were traditionally HIV assistance mechanisms, so that we could take advantage of them for this full array of the essential COVID response. So those are some thoughts that I'm looking forward to hearing the other panelists and our discussion. Thanks so much.
Great, thank you. Okay, so next we have Dr. Chukuba McLeod, I believe. We're going to you next, Muka.
Thank you, and good morning, good afternoon, and good evening. Many thanks to all the previous speakers for the excellent framing and insights. And thank you too for giving me this opportunity to share how practically a project, and in this case, USAID Discover Health, has leveraged PEPFAR to respond to COVID-19. If you will, my next slide. I don't think the slides, I can see.
Let's wait a minute for them to come up.
While the slides are coming up, perhaps I can go on just to provide a brief overview of USAID Discover Health, because our design and the decisions we made to optimize efficiency and effectiveness positioned us to quickly adapt and respond to COVID-19, including vaccination. In 2015, at Project Startup, our mandate was to take key HIV services closer to where people live, to address access barriers and to help decongest higher level facilities. We therefore primarily operate in facilities located in the heart of communities called health posts, which typically provide basic first aid services. With Ministry of Health approval, we expanded the range of services provided in our supported facilities to comprehensive HIV, mother and child health, family planning, and general outpatient services, immediately widening access and decongesting catchment area higher level facilities. During our life of project, we have operated in approximately 500 of 2,000 health posts in Zambia and established 47 new clinics in underserved communities with PEPFAR support. We are not a typical technical support project. We directly recruited and continue to support healthcare workers and community health workers who work alongside Ministry of Health staff to deliver our expanded range of services in these sites. Importantly, we invested in training our healthcare workers to multi-skill and deliver a one-stop shop service to our clients, a decision driven in equal part by funding dictates and client considerations. We could not financially afford siloed programs, and the workaround greatly benefited our clients. For example, a woman living with HIV and her child receive HIV care and child services respectively from the same provider. That's the way we are arranged. Although we provide an integrated service, our foundation is PEPFAR. 90% of our funding is PEPFAR. Next slide, please. In early 2020, when COVID-19 took hold globally and in Zambia, we quickly adjusted our operations to protect our staff and clients and to ensure continued delivery of critical HIV and other services. If we could go to the next slide, please. The previous slide. Thank you. We also immediately joined the Ministry of Health COVID-19 emergency response at all levels, including contributing to thought leadership. USAID Zambia has channeled 11.5 million of its COVID-19 funding to Zambia through USAID Discover Health to support procurement of equipment and medical oxygen for critical care management, human resource for health, and risk communication and community engagement, among others. Through the first 3 waves of COVID-19 and through partial lockdowns, our supported health facilities remained open and operational. Our staff, most of them supported through PEPFAR, continued to deliver essential health services and to provide screening, first-line management, and up-system referral for COVID-19. Next slide, please. Zambia received the first batch of 420,000 COVID-19 vaccine doses in April 2021. From October 2021, inflows of various vaccines have increased significantly, with approximately 3.6 million doses received as of November 31, 2021, most of them during the last 2 months. As of December 2nd, 2021, 8.4% of slightly 8.4 million people eligible, those 18 years and older, have been fully vaccinated. So we have a long way to go in terms of vaccination. Initially, widespread vaccine hesitancy was the rate limiter. Now demand is quite high, and the capacity of the health system to vaccinate the remaining 7 and vaccine availability are the rate limiters. Intensive vaccine messaging led by the Ministry of Health with support from USAID, Discover Health, and other partners, and a devastating third wave, which peaked around June and July 2021, have led to increased vaccine uptake. In September 2021, the Ministry of Health authorized provision of COVID-19 vaccination in the HIV treatment program, widening in-facility access beyond designated vaccination points. This is where our integrated design really pays dividends. With 2 million client encounters annually across services, we estimate we can potentially reach at least 300,000 eligible clients for vaccination, including 54,000 in our ART program. With our integrated service arrangement, we leverage PEPFAR and other platforms and provide COVID-19 vaccination in all service platforms, not only ART. As the data show, we are at around 8% of our target for ART integration, and for other programs, for all programs, we are at around 9%. It has not all been smooth sailing. There have been challenges. Vaccine stockouts affected our integration rollout. Just because vaccine is in country doesn't always mean it is available where it is needed. Stock levels are now improving and distribution is improving, allowing us to continue scaling up. We track vaccination refusal rate in our ART program. Initially, refusal was very high at 60%. After some program adjustments, especially providing adequate time for counseling, we are now down to 32% refusal. Next slide, please. On December 1, Zambia flagged off the December COVID-19 vaccination drive in a combined World AIDS Day and COVID-19 event, riding on increased vaccines availability and strong political will and leadership. Our rallying call is 2 million doses in arms by Christmas, which is a very ambitious target. The emergence of the Omicron variant, which has now been identified in the country, is the stakes and the urgency. For the month of December, we are orange like the Netherlands and the race is on. The PEPFAR program in Zambia through USAID, CDC, Department of Defense, and Peace Corps, and through implementing partners like ourselves, is fully supporting the Zambian government's vaccination efforts during the December drive and beyond, again leveraging PEPFAR where we can. USAID Discover Health is leading national RCCE for the drive and fully supporting the entire vaccination cascade in 2 of 10 provinces. Outreach vaccination teams combining Ministry of Health and project staff are fanning out into catchment areas to vaccinate door to door in workplaces, in places of worship and other congregate settings. Facility-based vaccination continues, including recalling our stable ART clients who are on long review cycles to come in sooner to get their shots. And that last point is important. Next slide, please. As we leverage PEPFAR for COVID-19, we have to be careful not to put so much stress on PEPFAR that we fail to respond effectively to both pandemics. We have to ensure good health outcomes for our clients on ART. We have to continue to find people living with HIV not yet on treatment and put them on ART for their own health and for HIV prevention. We have to provide PrEP to individuals at substantial risk of HIV. In USAID Discover Health, our focus has not wavered from this, even as we respond to COVID-19. In FY21, during the worst of the COVID-19 epidemic in Zambia, our overall viral suppression rate was 96%. We scaled up index case testing, surpassing our annual target for new HIV treatment and linking 100% to ART. We did not miss an opportunity to link people living with HIV to treatment. We contributed 31% to Zambia's newly initiated on PrEP, again, making sure that we protect people who are vulnerable to HIV through PrEP. It is a balancing act that requires keeping a close eye on program data and to inform decision-making. Fortunately, we have strong data systems built through PEPFAR to support this. Next slide, please. PEPFAR supports the COVID-19 response in Zambia, both directly and indirectly. Strategic information, laboratory, and supply chain systems strengthened by PEPFAR support aspects of the national COVID-19 response, as Dr. Sibrey mentioned in his earlier remarks. PEPFAR American Rescue Plan Act funds are being used to directly support scale-up of COVID-19 vaccination in the HIV service platforms, while staff supported by PEPFAR multitask to support above site level and community vaccination efforts. Out of necessity, albeit silently, we have leveraged the availability and the strength of PEPFAR from the outset of the COVID-19 pandemic. We didn't need to be told, we just did it. To us, the practical power of PEPFAR in enabling Zambia's quick and robust COVID-19 response has always been evident. It has never been more needed than now, as we race to vaccinate 7.7 million people as quickly as possible to try to blunt the impact of the coming fourth wave on Zambia and her people. And as we strive towards HIV epidemic control in the country, which thanks to PEPFAR is within our grasp. Thank you for your attention.
Thank you so much. That was great. Dr. Green, we'll turn it to you. And you have slides as well, correct?
I do, yeah.
Okay.
Thanks so much, Jen. Yeah, so I'll be presenting on 3 case studies related to increasing access to COVID-19 vaccines by utilizing the PEPFAR platform and focusing on increasing access and use among people living with HIV, people seeking HIV services, but also among healthcare workers and the general population. So next slide, please. So, with COVID, we very quickly pivoted and applied a framework of 3 intersecting approaches, really looking first at protection, equipping, training frontline healthcare workers to prevent, triage, and care for those with COVID, focused on ensuring access to PPP. And what I'll be focusing on for this presentation is on vaccinating people living with HIV, communities at risk, and the frontline healthcare workers that serve those populations. Secondly, maintaining continuity of care and services. And you've heard about the exceptional work that's been done through PEPFAR through the last 2 presenters. And so that, of course, has been a critical focus of our work as well. And then third, really looking at the PEPFAR platform as an opportunity to contribute to national and subnational COVID response, including and enabling general population vaccine rollout. And again, that's what I'll be focusing on for this presentation. So next slide, please. So, PATH is engaged in vaccine R&D and scale up over the past several decades. And there are 3 lessons that we've learned that are very salient now for COVID-19 vaccine rollout. The first is that vaccines don't deliver themselves, people do. And an essential foundation is that healthcare workers that are delivering vaccines are trusted by the communities that they serve. And second, that there is an investment in person-centered care over only a disease control focus, that it's really essential to have strong primary and community health systems that offer respectful and responsive care. And we see this so much right now in relation to vaccine hesitancy and some of the systems challenges with delivering COVID vaccines. And then secondly, or third and critically, is that communities play an essential role in engagement and addressing vaccine hesitancy. And this requires investing in partnerships between community organizations and leaders and healthcare workers. Next slide, please. So clearly over the past 4 decades in the HIV response, we have learned very similar lessons. And I want to focus on the third one specifically, which is the vital role that communities play in not only providing information around HIV services and now about COVID-19 vaccines, but also in advocating for monitoring the quality of services and delivering essential HIV services. So next slide. So I'll now be focusing on 3 key case studies around how PEPFAR has increased access to and uptake of COVID-19 vaccines. Next slide, and we'll focus specifically on 3 countries and 3 examples where the PEPFAR platform is enabling vaccine uptake among adolescent girls and young women in Kenya, among key populations, including men who have sex with men, transgender individuals, people who inject drugs, and sex workers in Vietnam, and among key populations who are in penal settings in Ukraine. Next slide. So focusing first on Vietnam, and next slide. So, PEPFAR over the past 15 plus years has invested in the development of key population-led organizations. And over time, this has led to their growth in becoming sustainable social enterprises and in opening their own primary healthcare clinics that offer HIV and other services that are recognized and endorsed by local health authorities. Next slide, please. So with the advent of vaccines becoming available in Vietnam, these clinics played a vital role in ensuring access to vaccines in the communities they serve. So from July to October, and this is now ongoing, the Department of Health tapped 3 key population-led clinics in Ho Chi Minh City and 1 in Hanoi to deliver 41,000 vaccines to people living with HIV, to key populations, and to the general population. And in a very short period of time, Vietnam has now surpassed vaccine coverage of the United States and is well on its way with mobilizing all key platforms like the PEPFAR platform to achieving a much higher coverage. So as well as part of the COVID response, the city has tapped these key population clinics to be part of the network of providing PCR and antigen testing for COVID-19. And next slide, please. So the support offered by these community groups has been deeply valued by government leaders. And this is a quote from the vice director from the HIV department of the Ho Chi Minh City Centers for Disease Control and Prevention, who said that the community has played an essential role in the COVID-19 response through the tremendous contributions that they have made to accelerate vaccine deployment and deliver online counseling, home-based care, and essential drug packages to communities who are in need. And next slide, please. So one of the very vital roles of key population-led organizations and clinics has also been in addressing vaccine hesitancy and really titrating the message based on the populations that are being reached. And so, for example, there's been concerns among transgender individuals around the interplay between COVID vaccines and the efficacy of feminizing hormones. And so it's been very important working together with transgender community leaders to understand the precise barriers to vaccine access and uptake, and then to communicate around the safety of COVID vaccines and support transgender individuals to increase their access and uptake, which is happening. And so again, very tailored messaging among people living with HIV, for example, among men who have sex with men and every other population that's being reached. It's been critical for really ensuring that it's possible to overcome some of the initial concerns that exist around hesitancy to uptake a COVID vaccine. Next slide, please. And as Dr. Siburi touched on, a major emphasis for us has, of course, been on maintaining essential health services. And so that's included really pivoting very quickly around rapidly scaling up the use of HIV self-testing, which was already widely available in Vietnam. And so with COVID, we were ready to scale access very quickly, and then also using telemedicine and other tools to maintain access to PrEP, treatment, and other services. Next slide. So I want to focus now on another geography. Next slide, please. And move to Ukraine. So in Ukraine, the USAID Serving Life Project has engaged with penal and detention settings across 12 regions of Ukraine and has focused on offering integrative, person-centered HIV, TB, and hepatitis C services, focusing around increasing capacity, increasing access to these services for penal populations, and increasing trust of these services. And so then, with COVID, we pivoted very quickly because of obvious concerns around rapid transmission in penal settings of COVID. And so that included rapid response related to prevention and also care. As of November 9th, we've seen very high uptake overall of vaccines among penal staff, penal healthcare providers, and the prison population. So just as background, by November 9th in Ukraine, under 30% of the population had received one jab. And so overall, penal populations that we're serving have higher level of coverage than the general population. Next slide, please. So now moving to Kenya, next slide. So here through the DREAMS program, which reaches around 45,000 adolescent girls and young women, the majority of whom are reachable through phones and online, we moved very quickly as well in Kenya to transition services to more online engagement with online safe spaces for DREAMS, as well as mobile services and home-based services. And so this platform then was ready-made for the arrival of vaccines, which included integrating awareness, raising around vaccines, and addressing questions one by one with individual adolescent girls and young women around concerns they might have around the vaccine. And so like in the other countries that I presented, we've seen overall higher coverage than national coverage within our program. So here, over 80% of healthcare workers have been vaccinated, 100% of DREAMS mentors, and around 50% of AGYW. And next slide, please. So in addition to working through the DREAMS program, overall, there's been very strong leveraging of the PEPFAR investment for testing, data capture, and supply chain within Kenya. And as well, which is very important, and we've seen across all geographies where we're working, is very strong syncing between the PEPFAR platform and other USAID investments like MRIGHT, which is focused on COVID vaccine introduction and scale, and with the Ministry of Health. Next slide, thanks. So moving forward, next slide, I think it's going to be really important to focus on how we are looking at transforming not only the COVID response through what we're learning, but also transforming the way that we work through PEPFAR and beyond. Next slide. So that includes really focusing on making sure that we are applying what we're learning through COVID-19 vaccine delivery and service adaptations through PEPFAR to enable stronger, better integrated and more person-centered responses, not only to HIV, but also part of integrated primary health care and emerging health threats. And next slide. And I think it's going to be really important moving forward in this moment to look at amplifying the PEPFAR platform as part of these global movements, as part of universal health coverage and health for all, and as part of that primary health care, and continuing to enhance what we've already seen as very successful response from PEPFAR as part of COVID, but overall as part of now global health security efforts. And with that, thank you.
Great, thank you so much. All three of those were amazing, and I have a lot of questions. I just want to encourage everybody listening, you can submit your questions through the Q&A or the chat. I think both will be monitored, but I'll start. Thank you so much. I have a lot of questions about the vaccine efforts that you've been able to accomplish. Two specific ones, and this just reflects questions I've heard asked just because it would be helpful information, and also some of the challenges that have occurred in the United States with our own vaccination effort. The first is when you are working in a country, and all of you gave examples, to aid in the COVID-19 vaccination effort, are you then, you're working with the vaccination supply that that country has, not a different supply, not something coming in specific for PEPFAR, it's the country's supply. That's one question. And the second question I have is, one of the issues I think that's increasingly important, especially with what's happening in South Africa, but it's we've known it, all of us working in HIV for all this time, that the people with HIV and those who may be immunocompromised in general or face other risks should be a high priority for vaccination. But not all countries they're making that kind of prioritization. So were you, in the countries in which you've worked, was that an issue, or were you able to work collaboratively with the government on this? Did they accept that that was important? I don't think all countries do. So this is an open question to everyone. First, on which vaccines, and second, on the prioritization of people with an at risk for HIV. Was that seen as important by the government, or something PEPFAR supported programs had to convey? Thank you. Who wants to just do a little this or just jump in? We're small, just a few of us. So, George.
Well, Jen, maybe I'll start with some general response and then probably get more interesting comments from Dr. Muka and Dr. Kim. You're absolutely right. There was no separate vaccine procurement or special vaccine supply line related to the PEPFAR efforts to promote vaccination. It was explicitly stated in the PEPFAR guidance that it couldn't, be used to purchase vaccine. And the whole goal was really to advance and support the national vaccine program for COVID. So it was supposed to be very complementary and move forward a plan that already took into account the context and priorities of the country. But perhaps we can hear some specific examples then from my colleagues.
Please jump in, Kim or Muka.
Speaking for Zambia, we did not have specific vaccine brought in for people living with HIV. The vaccine is through the government system, and it's through one supply chain system. And really, we only got vaccine in April 2021, and we got 420,000 doses, like I said. Between then and October, vaccine was trickling in, but we didn't have much. And it's only now that we are up to 3.6 million doses for the 8.4 million people we have to vaccinate. The Ministry of Health quickly recognized, working with its cooperating partners, including the PEPFAR program, that we needed, looking at the data that was available, that we needed to prioritize populations like people living with HIV to make sure that they are fully protected. And that's why they allowed integration into the HIV treatment program first before they allowed integration into anything else, really to just make sure that we protect people living with HIV. And if you have very few doses, when you make a policy change and you start implementing that change, you get tensions between supply and the demand. And as we started integrating, we started running out of vaccine in some of our sites because there wasn't enough to go around. And responding to that, that's when we started getting more vaccine starting from October up to now. Now we've got most of our vaccine in the last 2 months. But we started integrating as soon as the Ministry of Health gave its policy guidance, and it was vaccine availability that really slowed down our integration. But the Ministry of Health recognized, looking at global data that was coming out about the need to protect people living with HIV.
Yeah, I would just echo Dr. Muka's points, for all the three geographies that I described, particularly for Vietnam and Kenya, there really was a waiting on vaccine access and availability. But a lot of work was done to prepare for vaccines so that we'd be ready for their deployment. Of course, we were working with the existing Ministry of Health supply, and it's been a patchwork, as we know, right? And difficult for countries to predict what they'll be getting when. And so it's been so important for all Ministry of Health partners, including PEPFAR and PEPFAR's implementing partners, just to be ready and to be able to respond as quickly as possible. And I know has been said by all of us is that PEPFAR truly did enable that platform to move quickly. I'll also say that, the Ministry of Health in the 3 countries that we've worked with saw that opportunity. But also, huge kudos to USAID missions, and I'll call out the USAID mission in Vietnam, who played an instrumental role in supporting advocacy at the grassroots level, together with us, with EPIC, and with some local partners like the Life Center, to articulate the need to get vaccines rolled out as quickly as possible to people living with HIV in particular, but also that, key population clinics could play this instrumental role in increasing access to vaccines. There wasn't a lot of convincing that was needed in that regard, just because of the respect that's been garnered by these clinics overall by city authorities. And I just want to say, I saw Mitchell's comment or question related to PrEP and vaccine uptake. So I just wanted to take a moment to answer that quickly. So key population clinics in Vietnam distribute or serve more than 50% of PrEP clients. And so these clinics have just been essential for PrEP uptake. And so they then therefore have been really important to make sure that PrEP users were also vaccinated. So there's that strong integration between PrEP and COVID-19 there. Thanks.
Great, thank you so much. So this might be a question for George. These are amazing examples. And I think all of us working in HIV, and now, of course, all of us doing COVID work too, are just want to understand how to replicate those. And are these efforts going on in most PEPFAR countries, or are there some other barriers that might exist to doing so? Thanks.
Yeah, it's a great question, Jen. I mean, so much good work has been done, and I think we want to both have everyone learn from good examples and maybe from things that didn't work well, and make sure that the advantages and advances are happening across the board. So, one of the things we have tried to do is release initially weekly and now every 2 weeks guidance from PEPFAR to really highlight the ways that the overall PEPFAR program would like to see and would endorse adapting and providing this response. And I think that is a helpful way to put into one place kind of a reference everybody can look at that helps bring in examples, but also make clear, yes, you can use your PEPFAR resources for this, or here are the sort of limitations. Here are examples of what people have done. My sense is that, like so many things, the people working in these programs, can only be stretched so far. And I do think that aside from disruptions in commodities and vaccine supply, it is probably the workforce that I'm most concerned about. And that's where I think protecting the workforce, not just from COVID, but also from burnout, and seeing if there are other sources of funding or new sources of funding that come, how that could perhaps translate into additional workforce. Because I think the more people that are sort of expanding, working in these areas, the more we can get done. But for now, we're getting a tremendous amount out, I think, across every country where PEPFAR has a presence through the existing partners working at their mighty best.
Actually, you kind of anticipated my next question for everybody, Muka and Kim in particular, on healthcare workforce burnout, but also how, and you mentioned 2 other sources of funding. So with healthcare workers being sort of one of the main resources that PEPFAR can bring, and that you all have leveraged in your work, is what is needed to kind of re-energize them and sustain that work going forward? Is it additional health workers? Is it more funding for the existing infrastructure that's there? Is it both? What did you experience in or are experiencing in the countries in which you work in terms of your health workers and the need to address their needs? Thanks.
That is
Yes.
such an important.
Go ahead, Dr. Muka.
Thank you. That is such an important question, and one we are right now grappling with. We have so far not recruited additional staff for both above site and site level COVID-19 activities, including vaccination. We continue to operate with our original staff, both for PEPFAR and COVID-19. And this includes our above site experts, our healthcare workers, and our community health workers. We have absorbed and layered extra COVID-19 work onto current workloads, riding primarily on PEPFAR. That said, I have to agree with Dr. Savory. Especially at site level, we are beginning to see tensions. With COVID-19 vaccination integration into services, we have noticed that it is taking longer for our providers, slightly longer for our providers to see one client. And that adds up with time. As we scale up further, and given that COVID-19 vaccination is not a one-off intervention, people will need booster doses, at least once it becomes policy. In Zambia, it's not yet policy, but that is coming. I believe we will need additional site level staff in the near future in order to avoid long wait times for our clients and burnout for our staff. We are estimating right now around 10% additional healthcare workers and 10% additional community health workers, but we will be guided by our program data. And I want to just make a big shout out here to our healthcare workers and our community health workers who have really in pandemic. So the fact that we are estimating 10% additional staffing, these are the cost efficiencies provided by PEPFAR. A siloed COVID-19 program would have required 100% staff investments, but I think the tensions are beginning to appear. We will need additional staff just to make sure that both programs are protected, both programs continue to operate effectively. Our staff, we've protected them. When Ministry of Health first brought in vaccine, staff who work in the front lines were prioritized, and we did everything we could to have our staff vaccinated. We are at around 93% vaccination for our staff and community health workers. So we do know as we send them out there that at least on that front, they're protected. Thank you.
Please.
Yeah, I just wanted to add a few points to the brilliant comments made by Dr. Muka, and just to say that, I think we need to look at this in sort of what do we do, what needs to be done now, and what are we building towards? And in the now, clearly the burnout is so profound, and we see this across every geography where we're working. And I think that for sure, mental health support and making sure we have robust mental health services in place for healthcare workers and others who are impacted by COVID, including those that have or have had COVID, are available. That's a work stream in itself. But I think overall, it is these sort of relief, like rapid relief systems to make sure that healthcare workers can take a break and take a pause from being at the front lines continuously, which is effectively what it's been for the last 2 years, right? And I know each program is looking at ways to provide that backup support and to cycle healthcare workers in and out, so that there's a pause opportunity, because without that, there's just no way we can continue to function as everyone has in this high stress environment, and remain functional for what is to come. And as you said, Jen, at the start, we don't know what is to come, and surely it will not be what we're expecting. So at the same time, we need to be then investing in the longer term. And that truly is, I do think that PEPFAR has this potential to play a profound role in participating in these conversations around how are healthcare workers invested in, trained, and protected, particularly at the community and primary healthcare level, but not exclusively. So I think that this is an important moment to look at how more can be done in that area so that the workforce is better prepared, is more resilient, and moving forward. Thanks.
Great. And to the rest of the panelists, if you want to keep jumping in and respond to anybody else, please do. We do have a couple of questions in the chat, and I'll just refer to them because I think they're the really important ones when I was going to ask as well. A question that's coming up a lot in the context of PEPFAR and also of the Global Fund, as both have gone into this space and we're all talking about the future and how PEPFAR and the Global Fund can play an active role in thinking through pandemic preparedness. What are the risks that might be there that you see in terms of HIV services, and are there things we should be watching out for as we all agree that the PEPFAR platform is an important one for building out this response? What do we need to watch for so we don't lose our HIV services are focused and all those in your experience? Anyone can jump in.
I'm happy to come in first to get us started. I think the reality, of course, is right that we're not going to succeed with HIV if we don't deal with COVID, and we're not going to succeed with COVID if we don't deal with HIV, at least in high burden areas. So they are intricately linked. Successful management of both, I think, is intricately linked. I think PEPFAR's got a special commitment and responsibility to ensure that we protect the services for HIV and that we ensure that we remain on track. And that has to be the primary goal, even as PEPFAR advocates for full leveraging of its infrastructure. But in almost all the guidance, you'll see, the not admonition, but caution without compromising services to HIV. So I think PEPFAR will advocate that message to make sure that everybody, as we're planning, has an eye to that. And we will have to rely beyond PEPFAR, right, for the help on the full COVID response, even if PEPFAR is playing a major part of that response. But really, I think each time we make a plan, each time we put out the guidance, each time we see a project coming through, Jen, it has to be, an explicit reminder to ourselves, HIV front and center as we, move these other priorities along. Thanks.
And I'll just say, as the GAP, we feel very strongly that PEPFAR is the right platform. There are other platforms that are the right platform also, that the Global Fund and other platforms that are out there. We made I think George made a very powerful presentation about why PEPFAR is the right platform. But when we say PEPFAR is the right platform, we mean that it needs to be a resourced platform. When we talk about COVID, that we can't go forward, as George said, talking about moving forward with COVID when we had all of the success in the past 6 months. It was with the ARPA funds. And so moving forward, we need, those ARPA funds have all been obligated at this point, and the countries are now making strides with those ARPA funds. And so moving forward, we need to be able to have further funding to be able to have further strides and to do the work that Kim and Muka talked about. It is amazing that you saw some of the impact that both Muka and Kim talked about, and that's just within the past few months. So it needs to be a resource platform.
Great, thanks. Just want to point out, Chris Collins put a link in the chat to a new commentary that just came out that talks specifically about HIV as a platform for PPR. So if anyone is looking for that, it's in there. So one thing that I wanted to also ask, which is about funding, our future funding. As I think everyone here talked about, at least the most recent COVID-19 response in the countries in which you work is around vaccination. Prior to that, it was preparation for vaccination. It was around testing and all the other things that need to continue. But that's just in the last couple of months, and this is going to be a long haul effort. So going forward, if you were to have the opportunity, and I know George probably can't say anything about this, but if you were to have the opportunity to talk to Congress as they're thinking about, is there more needed? Is there other emergency funding that should be put out there? What would you say it would be for? Is it, with all of the things that you're trying to do with your existing PEPFAR support, what are the additional things that you're hitting up against and you can anticipate looking ahead will be the biggest barriers? Thanks. Kim?
You want to go for, okay. Yeah, I mean, I think that, PEPFAR has demonstrated how strong it is in addressing challenges in service delivery and service uptake, right? And really understanding what specific populations really need when it comes to service delivery. There's such a wide range and diversity of populations that are served. And I think that knowledge, that capability of how to understand what barriers might be for vaccine uptake and address vaccine hesitancy is going to be really important potentially for PEPFAR. I can see PEPFAR providers playing that role in sharing lessons learned, tools, and tactics, and how to address some of the vaccine hesitancy that's out there, and really supporting those last miles that exist, depending on which country you're in, to optimal vaccine uptake. I think the other piece really just has to do with supporting systems related to supply chain, related to supporting the health workforce, training, all of those systems related sort of approaches that are so important to ensure strong vaccine uptake and access, not only to the population served by PEPFAR, but just overall within a country. And then I think last is there's such great innovation through PEPFAR, through online platforms, telemedicine, and more, and that those could also be shared through PEPFAR implementers with ministries of health, and how to think differently about increasing vaccine access and uptake. Over to you, Dr. Muka.
Thank you, Dr. Kim. That is a great response. I don't have much else to add, but perhaps what I can do is just provide an example of Zambia from our currently available information and data. One of our biggest gaps right now is actually bodies to administer the vaccine. We do not have enough healthcare workers to quickly vaccinate the remaining 7.7 million people in Zambia and really get ahead of the fourth wave. For a task, the impending fourth wave, for a task of this magnitude, really, we should be all hands on deck and really looking at how do we get the people, the bodies to vaccinate people, to manage our data, to do all those things, risk communication and community engagement. All those things are important for an effective COVID-19 response. But I think we also internally have to look at what we do have now, because we do have some things right now that we can use. We do have some strengths that we can call on, while we also look at what we would like to have. For instance, in Zambia, we have the public sector and the private sector providers in all service platforms. We really have to move quickly to integrate COVID-19 vaccination, not only into the ART program, but into other service platforms, so that we fully utilize our available healthcare workers for vaccination. We do have those, and we should be looking internally to fully maximize utilizing our healthcare workforce. We have to maximally utilize the private sector for scale up. And this means clinics, pharmacists, and others. So we can tap into that resource that we have, and that will help us move forward. It's imperative that we continue taking services into community settings in order for us to quickly protect the remaining 7.7 million. We would like to ideally use healthcare workers for vaccination, but our situation is less than ideal. In the past, we have used trained lay community distributors to deliver DMPA-IM for women, for family planning. Could we, for instance, for vaccines like Johnson & Johnson that are not so cold chain intensive, could we train these lay providers to assist us to vaccinate during our current crisis? They have been assisting us in family planning for years and have been trained to manage data. So really, we have to think outside the box. Yes, we want healthcare providers right now, but we can look at these other resources that we have at hand and move forward quickly. But to answer the question that you asked, really, for us, it's bodies to vaccinate, the people to actually deliver the vaccine. We have such a big shortage, and then to manage the data so that we know where we are at as a country. That is another big gap where we're lagging behind. It's the people and training these people to enable us to respond effectively.
Thank you both. There was a question before, I didn't want to miss it, that similar to some of the things we've been talking about, with all of the expertise that PEPFAR and HIV service providers have on people-centered and differentiated service delivery approaches that are so about the local context. How do you, going forward, the question is, how do you see those approaches being maintained and scaled up for responding to both pandemics, which I think is similar to what we're saying. Like how do we keep what we're doing and scale these things up? Or maybe another way to ask it, is that something that you would want to see scaled up if you had to choose going forward as a critical area? Thanks. Anybody?
So I love to start because I like to be followed by people who give things I enjoy hearing better after me. So I'll start. I think that the silver lining with COVID has really been to watch the innovation and problem solving that's gone on in every context, and it's different for different contexts. And I've seen what I put in the chat were sort of two categories. In an effort to kind of deal with the fact you didn't want to bring people into facilities, or at least not as often, right? Accelerating things like 6-month MMD, decentralized drug delivery, transition to TLD, so a more streamlined, better drug, but streamlined commodity chain as well, right? Those accelerated in many places. So that was actually fantastic for an HIV perspective, and also met the COVID and enabled us to make faster progress on a priority that had already been established. And then separately, we saw innovations that hadn't necessarily been recognized before as ones we should do. Now, not all of them perhaps are things that we want to do forever, right? And I think what assessing as, did it work well? Did the clients like it? Did it achieve the goals that you hope to? I think in some cases, these virtual platforms, these ways to reach people in communities or even in their homes for testing a pregnant woman, or EID testing for a child that mom was reluctant to bring into clinic for COVID worries, right? I mean, those I think are great examples that you evaluate to see, did it work? Was it client-centered, client appreciated? Did it get the results you want? If so, let's keep doing it. We look forward to the day when COVID is handled, but let's keep doing this from an HIV perspective. So I think evaluating and being ready to just incorporate successful interventions and innovations into the longer term plan is going to be a good outcome of this tragic pandemic. Thanks.
Great. And if either of our others panelists want to speak to that, please do. Otherwise, I'm going to go on to another question.
Maybe just to add very briefly, so I think that what George is talking about, that learning and really understanding what is working, what's impactful, and what should be taken forward, and what is then the role also of PEPFAR and PEPFAR implementing partners and working with ministries of health to generate that evidence and to support policymaking, to encode some of these adaptations, I think is also going to be really important to look at. And maybe going back to answer your last question, Jen, around what is the next role to play. We looked at COVID adaptation policies globally, including for HIV, late last year, and they're fantastic. And they're all, what George was talking about in terms of just seeing some really important, impactful changes in and making sure that care is getting closer to what people need and into their communities, and all of the task shifting and sharing that we've seen, the use of the virtual platforms, which has been so critical. And really, frankly, just making care more person-centered in reality, because it had to become more person-centered, moving outside of facilities and getting care closer to people. So we saw all these great policies in place, but truly there are all these question marks around how they're working. But I do see that there is now movement, especially on telemedicine, where ministries of health are looking at how to nationwide apply and scale telemedicine. And I think that will be a global good that comes out of COVID. Yeah, the self-care agenda, all of the work around self-testing, self-screening, for example, that's happened around PrEP, and integrating self-testing so that people can monitor their own HIV status through telemedicine with a health provider, just to maintain that ongoing access to services. So I think this is a very exciting space, but I think it's one we just need to learn a bit more about, and so that we know what should be invested in moving forward. Thanks, and over to you, Dr. Muka.
Thank you so much, Dr. Siberry and Dr. Kim. I think you've said most of it. Just to give a practical example from our program on, for instance, 6-month MMD, when COVID hit, we had to call back our clients on ART and transition them to 6 months MMD. And we are doing the same now with vaccination. We learned that lesson through just protecting them from COVID and keeping them away from facilities so that their exposure is limited. We are doing the same now. We are recalling them for vaccination so that we use the same lessons we learned during the time we're protecting them from COVID. Now we are recalling them to come back and get their COVID-19 vaccination so that now they are further protected. So some of these adaptations we made, we learned good lessons that we are applying over and over again so that our clients can be as safe as we can make them during this difficult time. And that's the practical application that applies now to both pandemics and makes us keep our clients safe from both pandemics, in both pandemics. Thank you.
Please keep the questions coming. We have a little bit more time. I mean, I'm happy to keep going with mine. And while I wait, I do have a question. As you all were talking, one thing that we talked about before COVID, and we will talk about after COVID or during COVID, is the ability of PEPFAR and other HIV programs to quickly disseminate and get out new HIV interventions that may come. So when we have last acting PrEP. And I wonder if you could speak to some of the things that you've observed that facilitate, I mean, in so many ways, that while we wish most of countries in Africa had vaccines earlier, the fact that we have vaccines, you're getting them into people's arms now is an amazing, quick story. And so what are the things that we can take from that to apply to the next HIV intervention and innovation that comes? Or what would be needed to make that a success? Thanks.
Then I'll start. I think that COVID has shown us that we can do it, and that's the global we, right? That it is possible to respond quickly with new information and launch new interventions. I think even though we think of the PEPFAR and HIV response as an emergency response, PEPFAR is often as a tradition feeling like things aren't moving fast enough, right? That there's new information about a more effective treatment or a better way to deliver care, and it's not being taken up at scale. COVID has shown us it is possible that our normative guidelines generating bodies and colleagues, for instance, at WHO, they've been able to take in new information and turn that into updated guidance in a dynamic and rapid fashion. And I'd love to see how that can then be applied to HIV, where that timeline can be more rapid and adaptive, because it's important to have a body like that be objective and evidence driven for countries to look to when they think to their own. But then countries too, right, have just done an amazing job in the face of this pandemic of looking at new information and potential interventions, relying on their trusted partners to deliver those. But with circulars or rapid changes in policy or just permission to, move fast, they have done great things. So I'm hoping that it will be motivation and reassurance that it is possible and that we can carry that forward to be more rapid and dynamic to incorporate new evidence and new interventions for HIV services too.
Maybe Jen, because you opened the door for this, but just I feel like I have to say something about Cabela specifically and other new PrEP tools that are on their way or already are there, like the ring. What I hoped that we can see is some of this transference of emergency approval for products as part of the COVID response and these regulatory reforms, how we can tap into those to make sure that some of these really important innovations in the HIV space translate faster from FDA or WHO PQ approval to in-country use. So as much as we can be looking at creative ways to tap into those more rapid approvals, that will be, I think, really important. But then also just that these other PrEP technologies really just amplify this product mix, which is so important to reaching more people with PrEP. So we're meeting more people's preferences and addressing this unmet PrEP need that exists right now. And that we should utilize the differentiated approaches that have been applied through the COVID-19 response that Dr. Siberry spoke to and Dr. Muka has also talked about. Because I think that we see that we can make technologies, we can deliver them in ways that are simpler and that are easier to access by the community from what we've learned. With access through community delivery or mobile services or through pharmacies and so forth. So sorry, just a quick plug for PrEP products. Thanks.
Great, thank you. There actually is another question for you, Kim, in the chat that I think is a really good one. What did you, since you talked about doing these innovations with the DREAMS program in particular, what were some of the strategies you used or challenges you faced in doing that in Kenya? Since that's a very specific population, that often gets overlooked. Thanks.
That's an excellent question. Yeah, I mean, I think that, in March 2020, it seemed incredibly challenging. And what were we going to do to quickly change how services were structured, how outreach was structured, which is really built around in-person engagement and safe spaces inside often. And then linking AGYW to integrative health services, including family planning, MNCH for those that are pregnant or who have kids, and other health services as well, right? So that basically required a very rapid undertaking with AGYW to understand what they would prefer in terms of how they wanted to access health services, just understanding individually, one by one, issues related to stigma and whether it was appropriate to provide home-based services or if it would be better to offer mobile or online. And once that was understood, the services rapidly then pivoted to home, mobile, and online. And so family planning services, for example, or MNCH and HIV services like testing, PrEP, treatment, a lot of those were offered through mobile services or through home delivery based on what a given adolescent girl or young woman stated that they would prefer. So understanding those preferences first and then responding through these adaptations has been so important to maintain uptake and access of those services. And we did see a dip. So, in 2020, there was a decline in uptake, but as we really understood how to best adapt services, service uptake is now back up. And that's a trend also that Dr. Siberry described. So all of that, listening to the community, responding and adapting in the right way was really critical to making sure we could maintain access to a population that often does have challenges in accessing public healthcare services.
Thank you so much. As we are nearing the end of the session, I'm going to turn it to, unless there's another question that comes in, I'd love it if each of you just want to say the things you want to leave the attendees with, main points you would like to convey or statements you'd like to just underscore. Up to you what those are. But I'll start with, we'll go Muka and then Kim and then George.
Thank you, Jen. I think for me, it's just the appreciation of the PEPFAR platform and how it has enabled us to respond so quickly and so effectively to COVID-19. We've managed to respond while making sure that our HIV services are delivered and they remain quality services. Our clients are provided with the interventions that are keeping them safe. We've adapted the way we work and the way we look after our clients. And some of these adaptations have been really great for our HIV clients. We thought moving them to 6 months MMG, for example, would lead to some of them to drop off. They haven't dropped off. They have continued on our ART programs. And those adaptations have been very beneficial, and we should continue even beyond pandemics to maintain those. And continue to leverage PEPFAR. It's been a great platform for us. The lessons we've learned from PEPFAR, we can use those lessons for COVID-19, and the staff that we are using from PEPFAR to deliver our COVID-19 responses have been so very helpful, but keeping in mind that we have to make sure that we look after both programs so that we don't crash both as we try to respond and make sure that the integrity of both programs is maintained. Basically, by being very thankful for the opportunity PEPFAR provided us to respond.
Yeah, I think a few key points for me. One is, just tremendous recognition and gratitude to PEPFAR for really leaning in and providing that guidance so quickly, and really being very responsive, hearing to from the community what was working or not working, and adapting those guidelines week by week. That has been an outstanding source of support, and I think is a best practice in looking at how do you respond in a crisis. Secondly, I want to just go back to what I ended with in my presentation and what we've talked about is really looking at what are we learning, and what do we want to invest in moving forward in terms of what's working in service adaptations, what's working in terms of how best PEPFAR can support the COVID response, so that we are striking this balancing act of not jeopardizing the gains that have been made in HIV, but while really utilizing this very unique platform and this unique group of advocates, community groups, scientists, and others who are passionate about public health and passionate about equity and rights in healthcare. Thanks.
Thank you. George?
Having me follow Dr. Muka and Dr. Kim is not nice, Jen, but I would like to actually start by highlighting that I didn't talk about gender-based violence and how much of a concern that has been, just increased risk, increased occurrence of that in the context of COVID, and the ways that it's been important to adapt the PEPFAR gender-based violence reduction and mitigation and other services to be able to deliver those and reach people who might be sort of in their homes and with the actual perpetrators of that violence. So I just want to highlight that area as being so important since it was exacerbated by COVID, and PEPFAR had a unique, I think, opportunity to reach through the regular way, but also to adapt. The second major theme I would talk about is sustainability. So I think that we, rightly looked at PEPFAR's principles and applied them to COVID when it comes to services that are person-centered, strategic, high quality, evidence-based, and data-driven. And PEPFAR is also focused on, how can we make sure that it is sustainable, the HIV response? And I think that same question needs to come for COVID, which I think is going to be with us for a while, but also other pandemics and other health outbreaks like this. How can we make sure that the investments now are done in a way that they are sustainable and ready to not just carry us through the end of COVID, but also for the next threat that might come our way? Thanks.
Great. Thank you so much to all three of you. I have to say, I've heard several presentations on from sort of broad picture from OGAC that have been terrific, but to hear this level of specificity and information has just been great. Thank you so much. I'm going to turn it back to Helen and Gap to close us out.
Well, we cannot thank you all enough. You brought a level of, as Jen said, sort of aliveness to this question. And George, your framing was perfect in terms of laying out the framework of how PEPFAR sort of sits where it does and what different aspects it brings. And Dr. Kim and Dr. Muka, your level of specificity of what's happening in the field, but also bringing a human touch where that human touch is really needed, and reminding us that our healthcare workers are in distress right now, and that every day we need to keep them here. And we need to remember that remuneration is not enough, and that increasing the healthcare workers is not enough. We need both remuneration and we need the non-financial benefits. That rural workers need transportation just as much as they need remuneration. They need childcare, they need elder care, they need everything in terms of psychosocial support and recognition and appreciation. To keep going, as you said, Kim, that we need backup support. And so some of the things that I heard that were important is that innovations and that data and that the equity and holding our carers close to us, and the resource platform moving forward. So thank you to all of you. Our time is now up, but we hope that you learned something from this webinar today, and that you take away with you to keep moving forward and knowing that PEPFAR platform is out there. And thank you to the co-chairs, Kevin Fisher and Katie Koester, who I should have mentioned in the beginning. Thanks again, Jen, for moderating. Take care, everyone.
Bye. Thank you.
Thanks, everyone.